Okay, so let's discuss the next case. A 52-year-old man who's come in with a painful right knee. What's important to note here is that there's no history of trauma, and the patient was previously fit and well. Looking at the X-ray, both in the AP and lateral projections, we can see some very characteristic findings. There's this large, ill-defined lytic lesion in the distal right femur, extending through both the metaphysis and the epiphysis. The lesion has a moth-eaten or permeative appearance, which is always concerning for an aggressive process. There's also destruction of the cortex on the posterior aspect of the metaphysis. One thing that stands out is the periosteal new bone formation, which is typically a response to an underlying pathological process. Surrounding the lesion, there's some adjacent soft tissue mass, though we don't see any calcifications within it on the X-ray. Moving on to the MRI, things become a bit clearer. There's this large, diffuse lesion in the distal right femur, and it's associated with a small soft tissue mass, further confirming the aggressive nature of this process. There's extensive cortical destruction visible here, and the abnormal signal extends not just in the epiphysis and metaphysis, but also superiorly into the medulla of the diaphysis. This suggests that the lesion is infiltrating and replacing the bone marrow. There's also a pathological fracture through the medial condyle of the right femur, which adds to the seriousness of the situation. However, the proximal tibia and the joint space appear normal, and there's no focal fluid collection seen. Now, let's interpret what we're seeing. All the features here point to a destructive lytic lesion in the distal right femur, with periosteal reaction and an associated soft tissue mass. This lesion has infiltrated the bone marrow and caused a pathological fracture. Given the aggressive nature and these imaging findings, we need to think about what this could be. Let's move on to the differential diagnosis. For a destructive lytic lesion like this, particularly in a man of this age, we should definitely consider metastasis as a possibility. The other big ones we need to think about include osteomyelitis, though there's no obvious history of infection, and lymphoma, particularly primary bone lymphoma, which fits with the aggressive lytic nature of this lesion. We also have to consider the possibility of a primary bone neoplasm. This could be something like a reticulum cell sarcoma, multiple myeloma, osteosarcoma, or even Ewing sarcoma, though the latter is more common in younger patients. Given these findings and the differential diagnosis, the management plan for this patient is pretty straightforward. We'd want to refer them urgently to the orthopedic team. If we're suspicious of a primary bone neoplasm, we'd also involve the local sarcoma team. Further investigations would include a bone scan and a CT chest and abdomen pelvis with contrast to assess for any metastasis. An MRI of the femur would give us more information about local spread, and ultimately we'd need a biopsy to confirm the diagnosis. In this case, after the biopsy, it was confirmed that the patient has primary bone lymphoma. So let's talk a bit more about primary bone lymphoma PBL. This is a rare malignant bone neoplasm, accounting for less than 5% of all primary bone tumors. Most cases are of the non-Hodgkin type, and while PBL can occur at any age, the peak prevalence is usually in the 3rd to 6th decade of life. Interestingly, about 50% of cases occur in patients younger than 40, but it's quite rare in children under 10 years old. PBL is more common in males, with a male-to-female ratio of about 2:1. The most common site of involvement is the lower femur, particularly the metadiaphysis, and about 25% of cases have involvement here, which fits with our patient's findings. Other common sites include the upper tibia, humerus, pelvis, ribs, and vertebrae. Patients with PBL typically present with intermittent bone pain that can persist for months. There may also be local swelling, and some patients will have systemic symptoms like weight loss, fever, or a palpable mass, though our patient doesn't have those. When we look at the radiographic appearance of PBL, it can vary widely. Often we see bone destruction with a lytic destructive pattern, much like the moth-eaten appearance we saw in this case. Pathological fractures are common, occurring in about 25% of cases, which again matches what we've seen with the fracture through the medial femoral condyle. The periosteal reaction, along with soft tissue involvement, further supports the diagnosis of PBL. Treatment typically involves radiation and chemotherapy, and the prognosis for PBL tends to be better than for other primary bone sarcomas, which is a bit of good news for our patient. So to sum it all up, we've got a 52-year-old man with primary bone lymphoma presenting with a destructive lytic lesion in the right distal femur. The X-ray and MRI findings were classic for an aggressive, infiltrative process, and the biopsy confirmed the diagnosis. I hope this discussion helped clarify the key features of primary bone lymphoma and the importance of imaging in making the diagnosis. For more discussions like this, be sure to subscribe to Radiology Made Easy and feel free to share your thoughts or questions in the comments below.